Welcome to AETCM, the Emergency Medicine channel. Today we're discussing about a young male who came to AER with complaints of headache. So a 37-year-old male who came to AER with complaints of headache since past 3 days. The headache is more over the back side of the head, radiating to the front, and it aggravates usually in the evening time. So it has been there since past 3 days. He has been taking some medications at home, but it was still persisting, so he came to the hospital. He's a non-case of hypertension, but he's only taking one medication. There's Losar he was taking daily. And
what are the first line drugs used in hypertension?
Calcium channel blockers can be used. Then ARBs or AC inhibitors.
AC or ARB. Third drug?
Third drug will be then
diuretic.
Diuretic.
Calcium channel blocker, AC inhibitor, ARB or diuretic. Beta blockers were previously first line drugs. Now it is not there in the first line drugs.
CED. Okay.
It is not there in the first line
drugs.
But it can be used in a condition where the hypertension associated with CAD, ischemic heart disease, and some other conditions like stroke and all we can use.
So basically, this is a young male who came with complaints of headache. So when by initial impression he was conscious, oriented, obeying to my commands. When my primary survey, everything was in the normal limits. His survey was patent. There was no signs of any obstruction. Breathing part, he had a respiratory rate of 18 per minute and saturation 99% in room air. But coming to circulation, BP recorder was 210 by 130 on initial. BP was recorded and heart rate was 112.
What is the importance of recording BP in all the limbs in such cases?
Things actually sometimes a difference in blood pressure on like both limbs or something we can actually suspect, like an aortic dissection or something we have to suspect.
Aortic dissection normally you get hypotension. Yeah. What else? Aortic only. What you told is correct. Dissection as such will not produce high. It can produce, but by the time we see the patient may collapse.
Like, this thing.
Subclavian steal syndrome is different. That can produce, but not like this upper limb and lower limb difference. Coarctation of aorta. There you can get. Okay. Aorta arthritis.
Aorta arthritis.
Female patient, aorta arthritis.
So basically, patient came with complaints of headache since 3 days. I was taking some medications at home. It's not getting better. And on arrival, BP is 210 by 130. Heart rate is 111 per minute. And disability had a full score of GCS, and pupils are also checked. It was found to be 2.5 mm bilaterally equally reactive. So exposure part was having a normal temperature. So primary survey, the only issue is with the blood pressure and also some headache. So we initially gave him a 1 gram paracetamol for headache, and we continued a primary survey. So history is like he is having some acute onset of headache since past 3 days in series, but again progressive over time, along with radiating pain to the back also, and also it worsens in the evening time. He also had fever one day, but 2 days back, only 1 day. After that, it subsided. And also he had some intermittent palpitation histories also there. There's no history of any other cough, breathlessness, no abdominal pain, vomiting, loose stools, no other histories there. And there was also no complaints of any photophobia or any chest pain or anything. So only bilateral headache with some elevated blood pressure.
What's the age?
Age is 37. He doesn't have any history of any drug default or anything. He was regularly taking his medications and all that. His last review was about 3-4 months back. After that, he didn't have any review. So coming to the examination part.
Before going to that, what are the common conditions which can have high BP? Like Sir asked the age. This age group, what are the common conditions which produces refractory hypertension or very high BP? Refractory hypertension means we have to use multiple drugs. He was not using. But high BP like this.
One thing could be pheochromocytoma.
Okay.
Hypertension, hyperthyroidism.
Hyperthyroidism, pheochromocytoma. Okay then.
Then anything.
Renal artery stenosis.
Renal artery stenosis.
Then
he is obese. This fellow is very obese. What else can produce? Obstructive sleep apnea. That is one important. OSA also can present with high BP during daytime. Okay, OSA. Then you told pheochromocytoma, hyperthyroidism, Cron syndrome.
Cron syndrome.
These are the common causes in that they are not very common, but hyperthyroidism is very, very common. Here, since this patient is very obese, it can be
Secondary to OSA also.
OSA also. So we have to evaluate all these things.
It's a history of snoring also actually when he's sleeping. That's also there. So primary survey, one thing is actually he's having elevated blood pressure, and along with that headache. Headache actually subsided after giving paracetamol, came down. Right now the pain score is about 3. On arrival it was about 6 to 7. Now it has come down to 3. Secondary survey, it was the history, and on second clinical examination he was again conscious oriented. There was no parallel ictal cyanosis or clubbing. The BP is again still recorded to be high only. Pulse rate has come down to 103. And so clinical examination, chest was clear with bilateral equal air entry. S1, S2 was heard.
What chest finding you can get in patient who is having high BP?
One thing is actually there could be crepitations which could lead to significant early pulmonary edema.
Pulmonary edema. So pulmonary edema is a very important finding in high BP. If it is there, we have to treat very fast.
So chest was clear, equal air entry. Then cardiovascular system S1, S2 was heard. We couldn't observe any murmurs or anything.
What is a common cardiac finding in high BP? The commonest cardiac finding.
AR,
It is loud A2.
loud 8.
So if you look for loud A2, you'll get it. Okay.
Then abdomen was soft, not tender, and CNS is also full score. We took an ABG, VBG was taken at bedside because we just wanted to lot any elevated creatinine or anything in this thing.
Why in a hypertensive patient you have to take an ABG or like you told venous blood gas?
Venous blood gas actually, this patient doesn't have any tachypnea or anything, so we are not looking for any metabolic acidosis as such, but actually we want to, in our ABG we have a multi-parameter ABG, so we get some additional information like electrolytes and also creatinine value. So that just for that also we took an ABG.
What is the potassium in this ABG?
Potassium in this patient was 3.2.
Potassium is low.
Potassium is
If
low.
the ABG shows alkalosis, hypokalemia, alkalosis, hypertension, what is the commonest differential diagnosis?
Closest hypokalemia and renal loss secondary.
Conn syndrome. It is Conn syndrome. So hypokalemia, urinary potassium loss,
along with
and alkalosis. High BP, it is most possibly it is
Conn
Conn syndrome. That's why ABG is very important. Now here the patient is obese, you can see even CO2 retention also. If the patient is having OSA and secondary lung disease, you can get even carbon dioxide retention. So that is not there.
That's not there. So only finding was potassium was low 3.2, and sodium was 137, and creatinine was 1.6.
Okay.
The VBG. Okay. So basically, this patient has come with an elevated blood pressure with elevated blood with headache and elevated blood pressure. So he comes under the criteria of hypertensive crisis.
Okay. So in a patient who is having hypokalemia, tell me 3 investigations which will be sent from emergency room itself.
One is urinary potassium. Second, along with that, VBG to look for metabolic acidosis.
Renin and aldosterone.
Renin and aldosterone.
So potassium, urinary potassium, serum potassium, serum renin, serum aldosterone. Okay. You have 2 important conditions: high renin hypertension, high aldosterone hypertension. High aldosterone hypertension is Conn syndrome. High renin hypertension, it can be due to a renal disease. Okay. So both can be associated with hypokalemia. Okay. So if you forget it from emergency room, once you start beta blockers or AC inhibitors, then this test will not be valid. That is a problem. Okay. Once you see that potassium is low, immediately urine potassium has to be sent. Serum renin has to be taken. Serum aldosterone has to be taken. And if you start treatment, then you'll have to wait to stop the drug, which may increase or decrease the levels of these hormones.
So the next issue is actually now the headache has been controlled, but the BP is still elevated. So we are looking at a hypertensive crisis. So we have to think about whether it's an hypertensive emergency or an urgency. So this patient, the only thing that's pointing towards more in favor of an emergency is actually elevated creatinine. Doesn't have any previous CKD or anything, but the incidentally VBG is showing 1.6 of creatinine. And we are taking as both like a urgency or emergency. Our initial plan of management will be like to.
You want to see the fundus of the patient in this?
Yeah, this should be also be
What
checked.
you will get normally?
Thing is actually he's already a non-case of hypertensive patient. We have to like look for any long-standing retinopathy changes because of.
What is that retinopathy classification called as? It is Keith-Wagner classification.
Okay.
Silver wiring appearance, copper wiring appearance, bleeding tendencies. Then last one is papilledema.
Papilledema.
So here in emergency room for us, we have to see whether papilledema is there or not. Okay.
So anyway, our main aim was to like bring down the BP to like around 20-25% in the first hour. So we initially gave labetalol.
That is very important. Most of the doctors try to reduce the BP drastically with sublingual nifedipine. That is a wrong practice. If you reduce like that, what will happen?
There is actually a phenomenon called a J-curve phenomenon, because it has been studied mainly to like optimize the hypertensive management emergencies and in like in ICUs. So basically what they have found is actually sudden drastic drop in especially diastolic BP has more adverse effects than actual benefits. So patients who have been observed for a period of time with different line of managements, like some people actually the diastolic BP was actually maintained in case of they have a history of long-standing hypertension at a higher dose, a higher stage, and also some people it was drastically reduced to its normal limit. So basically, if a patient is coming with some 200 above systolic and diastolic 120, some people they reduced it to 120 by 80, and some people they maintained about 140 by 90 like that. Thing is actually what they observed is over time the people who are having reduced BP reduced to their normal levels had higher incidences of cardiac and like CNS and also renal dysfunctions noted.
So J-curve response means when there is high BP, it produces high mortality. When you reduce the BP to an optimal level, that is good. But if you further reduce it, it produces more danger effects than the good effects. Like in cardiac patient can have ischemic heart disease, patient can have kidney disorder. Okay, all can be produced. That is because our body is set for that high BP for a long time. Suddenly you are reducing the BP into a very low level. But brain will not be involved in this problem.
So basically, the study was initiated because they noticed a lot of people who were actually initially managed with hypertensive emergencies started having symptoms of like acute ischemia, cardiac ischemia, and they were even taken for angiogram. But most of the time, it came to be normal. So similarly, also this in patient also initially our plan was like control BP with labetalol and all that, but later he was admitted in like a HDU for further management, and he was started on NTG infusion. But over time the BP has been drastically reduced to like around 140, 80 and all that, and he was actually clinically stable, but his lab reports were showing slowly elevating cardiac enzymes and renal function were also altering over time.
So can you tell me what are the good drugs which can be used in a hypertensive emergency like this? And where will you reduce the BP drastically?
So initially our plan of management will be like to reduce the BP to about 25% in the first hour, then slowly bring it out around systolic around 160 over the next 4 to 6 hours. Then maybe around like 28 to 48 hours, like we will try to bring down to his baseline BP. So previously the idea was to bring to a normal BP, now the idea is to bring to his baseline BP. So if a hypertensive patient, his baseline may be even around 140, 80. So our aim is to bring to that level by around 24 to 48 hours. So initial line will be always be like an IV medication. What we have available is more labetalol and NTG. Labetalol we can give as intermittent boluses or maybe as an infusion. We can give like 10-20 as IV bolus, and then we have to like repeat the BP over time and then titrate accordingly.
There is no target organ damage, like target organ damage or a patient who is not having pulmonary edema or cerebral bleed, which will be better drug.
NTG will be better. Sure.
Ideally, beta blockers are better. Almost all types of hypertensive emergencies, beta blockers are the better choice. We can give beta blockers, and only in conditions where you have a very urgent reduction, like you have a bleed, you have pulmonary edema. In that condition, you have to add NTG. Otherwise, primarily, if you start NTG, BP may come down very drastically if you don't monitor the patient. Okay, but labetalol will give a more better predictable
drop in BP
response.
So IV, labetalol, and NTG are the best choices. We can go for a initial management, and once the BP is slowly coming down, we can actually add oral antihypertensives to add on the effect, and slowly after some time we can taper the other drugs. So basically, whether it's labetalol or NTG, we can't use it for a prolonged period of time. So once the labetalol is given, even after one hour, the BP may even rebound back to its normal state if you're not starting any secondary line of drug also. And NTG again, because of tachyphylaxis, about more than 24 hours, we can't give the patient on continuous infusion, because after 24 hours, the response to the drug ratio will come down, and so it won't be effective. So anyway, in ER, the first management will be like an IV antihypertensive, and once the patient's initial BP has come down and is clinically improved slightly, then we start on oral antihypertensives. So we can go with calcium channel blockers, or even this thing. Beta blockers, or whichever as preferred to the condition of the patient, and once the optimal dose has been achieved, we can slowly taper down our IV.
But this patient has
medication.
got LVH with strain pattern. ECG, if you see
ECG.
LVH with strain is there. So which will be the ideal drug to start?
This patient, initially we can start with
It is AC inhibitor.
AC
or
inhibitor.
ARB. Okay, it is like A, B, C, D previous guidelines. Now B is removed because of various reasons. A, C, D. Okay, so you have to start AC inhibitor or ARB. Only problem is if creatinine is very high, more than 3 and all, we should not try AC inhibitors. Once you start AC inhibitor, ARB, you have to monitor the creatinine. That's all. If creatinine is increasing, then we cannot continue. Or calcium channel blocker you can start. Or even diuretic you can start in ICU. Infusion of Lasix. Only thing is potassium was low here, so you have to give additional
potassium
and spironolactone.
Spironolactone.
Okay, but you have to see what is the urine potassium before starting Lasix. What was the urine potassium?
This one was 9.4.
It's low.
Low.
So that means the patient is not losing potassium through urine. So possibly Conn syndrome is ruled out.
So what happened to this patient was initially he was started on labetalol, then on NTG infusion, and once the BP actually went down and this cardiac enzymes got elevated, we also give cardiac compression and everything. But actually, while explaining to the patients, they insisted for the given for the option for coronary angiogram, they insisted for an option, and so we went ahead with a coronary angiogram. But it was found to have only a very mild CAD was there, which could be easily medically managed. So concerning the patient, it could be like a J point phenomenon, because secondary to that drastic drop in BP may have increased this cardiac enzyme, because it's elevated creatinine is also actually slowly coming down after we stabilize this blood pressure and all that. So after the sudden drop in blood pressure, we actually then correctly monitor the patient and actually then stabilize his blood pressure medications and all that. So now actually his all lab reports are coming back to his normal level. So what happened to this patient was initially we managed the headache with pain medications, and for completion sake we took a CT brain also. It was not showing any acute bleed or anything. Then hypertensive emergency, we started him on labetalol as a stat dose, and then started him on NTG infusion. Along with that, supplemented with some calcium channel blockers, and again ARB was also started. And in between, because of the elevated cardiac enzyme, we went with the CAG. It was not showing mostly normal coronaries only. So start on medical management, and then after that, after optimizing the antihypertensives, actually all his lab reports have come back to his almost normal limit. So our primary aim right now is actually to optimize the medication so that we can continuously completely stop all the extra medications and discharge him with a proper dosages.
Okay, but he has got snoring, he's obese. What else you had to rule out?
So the plan is actually, once this initial event everything is stabilized, our plan is to advise him for a proper pulmonology review, because this OSA could be an initial trigger for his early hypertension at a young age. So we are also advise him for lifestyle changes to reduce his overall body weight and everything. And also our plan is to show to a pulmonologist for sleep study and all in the further review.
What is sugar level?
Sugar's HbA1c was 5.2.
Not.
On arrival is 123 GRBS.
So how do you treat the OSA part?
OSA part actually, if again sleep study is showing significant hypoxia during sleep or anything, we have to advise him for CPAP or anything at night.
So mostly this patient may require CPAP ventilation during night time, because he is having severe snoring, obesity, high BP, high hemoglobin content. What is the hemoglobin?
Hemoglobin was 17.4.
Hematocrit? That is a 51 something.
Ah.
Okay, that means it is secondary polycythemia. Where will you get secondary polycythemia?
Basically, in a normal patient with some low level of oxygen in the blood, could be like in smokers or maybe even in case of OSA or anything. Yeah.
You have to see what is his personality because Gerspo phenomena is there. In that hypertension and anxiety, polycythemia will be there. So that's a combination of problems. So that also should be ruled out. So
What is the occupation of this patient?
Occupation actually basically this thing. He's working in a shop.
Knocking in the shop, okay.
like
See,
a
whenever
sales
this
representative.
obesity patient, you always keep about the short neck. Short neck.
Short
Whether
neck,
the neck is short, see, two things. One, it may worsen the sleep apnea condition. Another thing, when a necessity for an intubation, this should earlier evaluated better. Keep in mind about that. Okay.
So, do you think that this patient is having renal artery stenosis? How do you rule out renal artery stenosis?
One thing is aldosterone.
One is you do a Doppler and rule out renal artery. Second thing is you already started AC inhibitor or ARB. If there is renal artery stenosis, then definitely patient will creatinine will increase. So that is paradoxical hypertension. When somebody is having renal artery stenosis, when you start AC or ARB, creatinine increases. Creatinine can increase without a renal artery stenosis also. But renal artery stenosis, if it is present, there will be rapid elevation of creatinine. So that is not there. You can safely continue.
So currently the patient is actually doing fine. He's like all infusions, everything is stopped, and he's on multiple antihypertensives. BP, everything is maintained. His now average BP is around 150 like that, but he's symptomatically better. Headache is also like completely gone.
Okay, so this is a case of young hypertension who had high BP on reduction. There was little hurry and rapid reduction increased the cardiac enzyme without any
actual coronary disease.
So this is called as J-curve response.
J-curve response.
Other one, potassium was low. It can be due to something else, but here we have ruled out Cone syndrome. So potassium is what is the action of potassium in blood vessels?
Basically, it has a vasodilatory action.
So if potassium is low, it produces vasoconstriction. BP increase. Once you give potassium, vasodilatation occurs. Magnesium was done?
Magnesium was 2.4.
That is normal. Okay. Any urinary findings you saw in this patient other than that? Urinary infection or urine pH? There's no other issue.
No other issue.
Echo was
was showing concentric LVH.
LVH. Okay. There is no diastolic failure.
No failure as such.
Okay. Anything else? Sir?
No.
See, regarding this patient, suppose you are having a necessity to go for an RSI. So, how will you proceed about?
One thing is actually this patient is an obese patient. So, thing is, even if we plan for RSI, we have to initially evaluate him for like any difficult intubation possibilities. One thing is short neck, then also difficult ambu ventilation could also be about this thing. So, if required, we can put an OPA after initial sedation if you're not able to ventilate properly.
In such cases, NP nasopharyngeal airway is a better choice. They will tolerate much better. When mild sedation also, just explain the patient clearly what you are going to do it and what is the benefit he is going to achieve. Then definitely the patient will be understanding and then accept it. Lubricate well, gently insert it. Okay.
So this patient has actually very high prone chance of like tongue fall and all that. So we have to like properly head tilt and chin lift the patient before this thing.
That's why the nasopharyngeal airway will overcome all these
so
things.
An adjunct
Tongue
will be
falling,
like
it will
preferable.
prevent.
So we have to use, and most probably will require an adjunct to properly ventilate the patient. Then again, ambu ventilation also we have to properly get adequate seal, and this position should also be done.
He may require some additional pressure. We have to exert more
because of his obesity and
inspiratory pressure.
Intra-abdominal pressure will be more.
And the positioning, it will prop up. At the same time, keep in mind the recently administered antihypertension. Postural hypertension may be a possibility. Okay.
Have you ruled out pheochromocytoma in this patient?
This patient,
how do you rule out?
We had to L24 VM.
So the problem is you are giving beta blocker as a first line drug in emergency room. What happens to the BP in pheochromocytoma after giving beta blocker?
Fluctuating.
It increases. That is a problem. Because unopposed alpha action.
Okay.
Beta is blocked.
Beta is
So
blocked.
there will be a drastic increase in BP. So any patient whose BP is increasing after beta blocker, young patient, palpitation, sweating, BP increases after beta blocker, then you have to think about pheochromocytoma. If you are thinking about pheochromocytoma, you are not supposed to give beta blockers. You have to stop beta blocker, give some other drug, control the BP, then only you can do the VMA and metanephrine test. Okay. So we are possibly ruling out many things with our initial treatment. But ideally, when you are suspecting young patient coming like this, when you are giving drugs, you have to be very careful because some of the conditions you may be masking. You have to be very careful in starting drugs. And drastic reduction of BP is not required in most of the conditions. Only 25% of the existing BP reduction is enough. And if there is pulmonary edema, you definitely have to treat with NTG infusion. If there is bleed in the brain, you have to control with labetalol.
Then I have to
Dissection also you have to control very fast. Other things, other conditions, time is there. Okay.
Okay.
Anything else, sir?
Okay.
Thank you.
Thank you.